Sir, is it clear? The audio video is clear, Dr. Pemde? Still setting up.
So I'm putting on the broadcast. Okay.
Okay.
Hello,
Yes,
Dr. Pemde. Hello.
Hello. Good afternoon.
Yes, sir.
बस बढ़िया है.
हाँ, हाय शोभना आप अपना वीडियो ऑन कर लीजिए.
Hi, Dr.
So
Shobna.
all are live now.
Okay.
All right. Shall we start now or within
I
few
think-
minutes?
I think we can let people join. Let
For
some of the people.
1 or 2 minutes. After 1 or 2 minutes, we can join.
Right.
Hello, Dr. Harish. How are you?
Hello. Hi. Fine. Good. Okay. बैकग्राउंड में क्या है ये? PGI का?
PGI के लोगो लगाए हुए हैं.
अच्छा, good.
We can't be Bollywood stars with those now, so we can at least use these. Yeah.
चलो, मुकेश आपके पास है हमारे यहाँ से? दीपक, डॉक्टर मुकेश आपके साथ है ना हमारे?
Sorry. हाँ. Yeah, he's doing well.
I think Roshani, we can join. Start now. It's already-
Okay, fine. Very good afternoon, everyone. Myself, Dr. Shalini, Secretary IEP North Delhi. Welcome you all for the last day of Hematocon. Today, I won't take much time. We have Dr. Harish Pemde, sir, who is a Joint Secretary licensed to see IEP. So we all welcome you here. And we
Thank you.
have Dr. Shobna Gupta and Dr. Anuj Goyali, IEP. And I welcome all our dignified speakers with their brainstorming presentation today. And the IEP, not only IEP, welcome you all, sir and ma'am. Thank you so much for being here. It's an honor for us. I would like to invite Dr. Pemde, sir, to say a few words. Sir, please.
Okay. Thanks, Shalini, and thanks, Dinesh and Manas. Sorry, I could not come on the day one, but I was told that this is a hugely successful program. 450 plus people have joined. I think this is the strength of this medium. Otherwise, you could have taken hardly 45 people in a direct workshop. So at the same time, you are training and teaching many people. And I hope that this workshop will not be the first one only from, this is the first one, but will not be the only one from IAP North Delhi. You will be doing many such similar programs in future also. And I hope this workshop where we are training more than 400 plus people, and they will also be practicing some hematology in their primary care. And this will lead to development of shared care environment for hematology patients, because I know that there are large number of hematology patients which require specialized care, which is not possible given the number of hematology patients which are there. So I hope this workshop will pave the way for a kind of a shared care environment where some care is provided by primary care pediatrician and special care is provided by the hematologists, hematology pediatricians. So I cannot say that best wishes, it is already 3 days are over, but I would say best wishes for the participants who will enter into this enhanced hematology practice. I would say enhanced because every pediatrician is treating anemia and doing some hematology, but they will be doing now enhanced hematology practice. So best of luck, best wishes to all of them. And thank you.
Thank you. Thank you very much, sir. We have few miscellaneous topic for today, miscellaneous hematology. And the first topic would be on cord blood banking, whether it is a hope or overhyped. Speaker is with us, Dr. Revati Raj from Apollo Hospital, Chennai. welcome you here. Thank you for being here with us. And now I will hand over the session to Dr. Manas Kalra.
Good afternoon, everyone, and I would like to welcome you to the last day of Hematocon. Thank you all for a very enthusiastic participation. I apologize for the minor glitches that we had, some technical issues, some other issues, but I think more or less things have gone very smoothly. This is our first attempt of doing something online, and the response has been really amazing, and thank you for that. To kickstart the day today, we are going to have a topic which is a little out of the sync of the rest of the topics, and this has come up because a lot of pediatricians wanted to listen about cord blood banking. This is something that being advertised in a big way. There is a huge market, and a lot of cord blood banks are available. The field of stem cell transplant is evolving by every day. So is this something that we should be doing? Is this something which is mandatory? Is it something which is going to save lives? And if at all it is, then how do we get the resources? How do we get all the everyone ready to be able to do this? So let us talk about this. And for this presentation is none other than Dr. Revati Raj. Dr. Revati is a very senior pediatric hematologist, oncologist, and BMT physician of our country. She's a very respected member of the PHO chapter. She heads this unit in Apollo Chennai, and she actually set up the whole pediatric BMT work there. And and she's one of the pioneers of doing cord blood transplants in the country. So I think she's the right person to deliver this talk. Over to you, ma'am.
Thank you, Manas. It's a pleasure to be here today, and I want to thank the IAP of Delhi and Manas and his team for this opportunity. And let me just get my slides up. Give me a minute. Are you able to see my presentation?
Yes, ma'am. Yes.
Yeah. So the topic given to me is about.
You can put it on the play mode, then the whole screen will be flashed.
Oh, I will. Is this better?
Yes, perfect.
Yeah. Okay. Thank you so much. Yeah. So again, just to go back and say thank you for this opportunity. And actually, it was good for me to look at this topic as well, because I revisited and went down memory lane on what we did with the cord blood transplant. So thank you, Manas, for the opportunity. And what I'd like to do over the next 20-25 minutes is to give an overview of what we've done so far and what is going to happen in the future. So this is the outline of my talk, and this is a little brief introduction on stem cells, the myths and facts, and talk about the hematopoietic stem cell transplantation, the journey, and a little bit about cord blood stem cells, because the whole topic is there hope, is there too much hype? And I wanted to share some stories with the hope and hype stories. And finally, for our pediatric colleagues, what advice should they give, whether they should tell their patients to bank or not to bank cord blood. So I would like to cover all these four components over the 25 minutes. So stem cells, there is a lot of hype about them. There's myths, but the fact is that it's...
Your video, please. Can you switch on your video, please?
1 second. Are you able to see?
Yes, ma'am. Yes, ma'am.
Yeah.
You can see.
Go back to the PowerPoint. Okay. I think this is better. Are we all set?
Yes, ma'am. Perfect.
So, people thought that stem cells are the cure to all ailments in the human body, but we need to know that there are several different types of stem cells. One is totipotential stem cells. So you have the egg and the sperm fusing, and then you have the human embryo, and that can give rise to all cells of the human body. And from there, you have pluripotential and multipotential stem cells, and these can give rise to different cells of that particular organ only. So, for example, if you take hematopoietic stem cell, it will give rise to red cells, white cells, and platelets. But it cannot, for example, make nerve cells or heart muscle. So, embryonic cells are the ones that have potential to develop into all sorts of cells of the body. And from embryonic stem cell lines, we can make dopamine producing nerve cells, retinal cells, islet cells of pancreas in a petri dish, given the right environment. So, the adult stem cells can either form nerve stem cells, cardiac stem cells, or and they give rise to cells, different cells of that particular organ only. So this is a big difference, embryonic and adult stem cells. So adult stem cells are committed and they belong only to that particular organ. So we should not confuse between totipotential and multipotential stem cells, because this is where there has been over time a lot of confusion regarding cord blood stem cells. Because it comes from a fetus, people often confuse cord blood stem cells as being embryonic and having totipotential capacity. But they are only adult stem cells. Human umbilical cord blood stem cells are just excess hematopoietic, blood forming stem cells of the fetus. The fetus is making a huge amount of blood forming stem cells, and one particular portion of it is in that 100 ml of cord blood that connects the baby to the mother. So the adult cord blood stem cells are only adult stem cells. They're pluripotentials, not totipotential, and they can only make red cells, white cells, and platelets. So primarily, they can be only used for treating blood disorders. So this is, I think, the only take-home message I'd like people to take. This is what we are looking at for the future. This is magic in the lab. We now have potential to take skin fibroblasts, reprogram those skin fibroblasts, and give them the potential to grow into any cell of the body. So you're really doing genetic reprogramming. So these are called induced pluripotential stem cells. And this genetic reprogramming has really paved the way for a lot of regenerative medicine studies. So these are true cells with totipotentiality. So, but we still don't know how to harness the potential. We know we can reprogram them, but how many cells to give, what are we going to do with them, how are we going to inject them, we still haven't figured out. So I'll just wrap up the first component of my four parts of my talk to say that there are embryonic stem cells, there are adult stem cells, and there are induced pluripotential stem cells. Embryonic stem cells are totipotential and they can give rise to all cells of the body. If I'm using embryonic stem cells, then there are ethical considerations, because technically you are aborting a fetus to do your research. Adult stem cells, like the hematopoietic cells, cardiac cells, and nerve cells, they can give rise to only that particular cell line of the body. And here there are no ethical issues in the use of hematopoietic stem cells, because these are self-replenishing. If we donate stem cells today, in a week's time, we will have these stem cells coming back in our body. And the induced pluripotential stem cells come from our skin fibroblasts. And again, at this point, there are no ethical dilemmas involved in the use of induced pluripotential stem cells. So the next component of my talk, I'm going to take you through transplant. When we do hematopoietic stem cell transplant, what is the journey? What happens to these patients? And it is like planting the seeds of happiness, hope, success, love, everything. And you would see when it's successful, how beautifully the children get transformed of their blood disorder. So hematopoietic stem cells are like the seed sitting in the spongy bone marrow, and the bone marrow gives juices that are required cells to grow and to make red cells, white cells, and platelets. And this happens every day. The heart ticks in our body, we're aware of it, but the bone marrow works really hard, and we're not aware of how much it does until it actually stops working. So every 2 days, we have to make white blood cells, every 10 days, platelets, every 120 days, red cells. So transplant is taking the entire hematopoietic stem cell from one person to another. So transferring these pluripotential stem cells, that is called hematopoietic stem cell transplant. If the source of the stem cells are from the bone marrow, we call it bone marrow stem cells. When it comes from the blood, we call it peripheral blood stem cell. If the stem cells come from cord, we call it cord blood stem cell. But essentially, the process of transplantation is the same, whether we use bone marrow stem cells or cord blood stem cells or peripheral blood stem cells. The procedure and the process is all the same. So if we take a person's stem cells and give it back to them, it's called autologous. If we take it from one person and give it to another, it's called allogeneic. And autologous, the uses are very little in children, very few indications. When we want to give a child high doses of chemotherapy, which the bone marrow will not tolerate, but for their solid organ malignancy, we use autologous stem cells as backup. We take their stem cells, keep it in the freezer, and give the child high dose chemo. But I'm not going to touch upon it right now. So what are the conditions for which we use allogenic transplant? You have stem cells, and when the stem cells completely stop functioning, that's called aplastic anemia. From the stem cells, we produce common lymphoid progenitor and myeloid progenitor. And you know that there are lethal blood disorders like primary immune deficiency disorder, severe combined immune deficiency, where the lymphoid system doesn't function properly. And this can be cured using transplantation. From the myeloid precursors, we get the neutrophils, red cells, and platelet-forming system. So disorders of these, like acute myeloid leukemia or lymphoblastic leukemia, which do not respond to chemotherapy, can be cured using transplantation. So for all of these, we use transplant. So stem cell disorders like aplastic anemia, red cell disorders to cure them of thalassemia or sickle cell anemia, white cell disorders like high-risk leukemia and primary immune deficiency, platelet dysfunction, metabolic disorders. Here we are targeting the monocyte macrophage system. So in these mucopolysaccharidosis, the monocyte macrophage system is involved in the storage component. Osteoclastic defect. Osteoclasts also come from the blood-forming stem cells. So osteopetrosis can be cured using transplant, and macrophage defects like genetic type HLH can be cured using transplant. So I want to take you through step by step how we perform a transplant, and here it's a good way to remember the 7 steps. So when we get married, we go down around the fire with a partner, and that's called Saptapati. So we have 7 steps of transplantation. In step 1, you need an ideal patient. So we can't transplant everyone. The patient has to be ready for the transplant. So I just put this case to highlight what I mean by having an ideal patient. I took a common example of a child with thalassemia major. So this is a 15-year-old boy, and I've placed him next to a 15-year-old girl. And you can see that lifelong he's run a hemoglobin of 4, 5, inadequately transfused, received no chelation. Transplanting this boy would be very dangerous because his whole body is filled with iron. So there's heart iron overload, liver iron overload, and the first step of transplantation is to give these children high-dose chemotherapy. He is not ready, he will not cope, even if he has a fully matched sibling and ready for transplant. Whereas if the child has had a transplant early, as in this case, the family had a fully matched twin. One child is the patient, the other child is the donor, and the outcomes are so good when we do early transplant for thalassemia major. So we have a patient. Next, we need a donor. So how do we choose which donor? So for this, we have to remember that the body has a beautiful mechanism of recognizing self from foreign. Self, I will accept. Foreign, I will reject. And the cleverest cells of our immune system are lymphocytes. So lymphocytes are capable of recognizing self from foreign. And we have a human leukocyte antigen in all the nucleated cells of the body. Red cells and platelets are non-nucleated. That's why we are able to transfuse them from one person to another without tissue typing or HLA typing. But all the nucleated cells of our body need HLA recognition to be accepted or rejected. So HLA has class 1 has A, B, and C, and class 2 has DRB1 and DQB1. So totally, there are 5 antigens which come from our mother and 5 antigens that we acquire from our father. And the chance that me and my brother would have all the 10 antigens very similar from both parents is only 30%. So only 1/3 of our patients who need a transplant have a fully matched donor within the family. The other 70% need a transplant, but they don't have a donor. So what do we do for these patients? We have now access to unrelated registries worldwide. So worldwide, there are about 25 million donors registered, and this has become far easier in over the last 10 years because we now have Indian registries such as Datri, where adult volunteer donors have done their HLA typing and wait to be called. So if there is a patient in need of a transplant, I enter their HLA on the computer. All the 25 million donors worldwide are connected through a network, and we do a search. So my patient in a village from Tamil Nadu could have a fully matched donor in Germany, and it's still possible to bring those donor stem cells to India and transplant them and cure them of their blood disorder. So Datri is the Indian registry, and I would appeal to all the younger colleagues to register as an unrelated donor, because out of the 25 million donor database, over 23 million are Caucasian. So Asian and African patients have a very little chance in these registries. So sibling donor is the easiest form of transplant we can do, because within a family, the mismatches, minor mismatches are few and far between. And this is a baby who had come with severe combined immune deficiency years after transplant, looking so beautiful. This little boy came from Pondicherry, and he had Wiskott-Ulrich syndrome, and he's had a matched unrelated donor transplant from a donor cured of his Wiskott-Ulrich syndrome. The beauty of transplant is that this field keeps advancing every day. Hopkins University in the US, basic research had shown that if you have a half-matched donor, so my mother is half-matched with me, father is half-matched with me. So when I get those stem cells from them, the lymphocytes from the donor start rapidly recognizing the patient and growing and getting ready to attack the patient exactly at 72 hours. So day 3 and day 4 are very crucial days when we give mismatched lymphocytes. So in Johns Hopkins, they've used this very, very simple method of using cyclophosphamide on day 3 and day 4. Cyclophosphamide is an inexpensive chemotherapy which we've been using for decades. And this selectively removes the lymphocytes from the donor without damaging the stem cells in any way. So this has formed the basis of haploidentical or half-match donor transplants all over the world, and it has actually revolutionized the whole scenario of transplantation. And there are other ways of removing donor stem cells, which can be done by a machine called the Clinimax. So if we didn't want to give the child cyclophosphamide, we can remove the stem cells using the lymphocytes using magnetic beads as well, from which we've done transplants. This is called TCR alpha beta depletion. So we have a patient, we have a donor, we have to prepare the child to receive the new stem cells. So how do we do that? This is called conditioning. This is the most crucial part of the transplant. We have to remove all the stem cells in the child, remove all the lymphocytes in the child so that they will be able to receive the new stem cells. If any of their lymphocytes stay back, they can reject the new stem cells. So we have to create space and make the patient so immunosuppressed that they will be able to accept the new stem cells. After conditioning for 1 week, where we use high doses of chemotherapy or radiotherapy, we infuse the stem cells that we are collecting. So my dad always thought I was a surgeon. When I was doing bone marrow transplant, he thought I was cutting up bones and trying to put them back, but it's a medical procedure. If we are collecting stem cells from the bone marrow, the donor is under anesthesia, and from the posterior iliac crest, we do multiple iliac crest punctures and remove the bone liquid and put it in a bag for infusion. If we are collecting from peripheral blood, this is the kind of collection that we use most often these days. We give 4 days of injections, GCSF injections. So about 1% of the stem cells come into the peripheral blood, and the donor goes through a procedure like platelet apheresis. The stem cells are collected over 90 minutes to 2 hours. So this is a simple office practice donation. So if we are an unrelated donor, our donation will also be as simple as this. So I would encourage as many people to register as an unrelated donor as possible. Cord blood, the baby is born, the cord is clamped and the baby is out of the picture, and the placenta, when it's still in situ, we cannulate the cord and we collect the 100 ml of blood. This is Dr. Broxmayer, who said that cord blood is a rich source of stem cells, hematopoietic stem cells. And Dr. Gluckman in Paris has done the maximum number of cord blood transplants in the world, and she was the first to do a sibling cord blood for a child with Fanconi anemia way back in 1989. And Dr. Rubinstein in New York, the New York Cord Blood Bank pioneered how to do cord blood banking on a large scale. So this became the biggest advance in the early 2000s. And cord blood banks started collecting a lot of the stem cells. And once the stem cells are collected, they are processed, and they will exactly come into a 25 ml bag like this, which can be put in liquid nitrogen. So we mix it with a chemical called DMSO and put it in liquid nitrogen. Now, liquid nitrogen always keeps evaporating. So they have to keep adding more liquid nitrogen to the tank to keep these cells alive for 20 to 25 years. That is why the cost of cord blood banking over 20 years goes up, because we have to keep replenishing the liquid nitrogen all through. So once the transplant center wants the cord, it is issued to the transplant center. We defrost it in a water bath like this, and from a frozen block of ice, it becomes liquid. And whether it's peripheral blood stem cells, bone marrow stem cells, or cord blood stem cells, the infusion is the part that is easiest. So the stem cells are connected to a central line and given over 1 hour. So these cells will go into the body and they have to make new stem cells. This takes time. It takes about 2 weeks if we use peripheral blood stem cells, 3 weeks if we use bone marrow, and 4 weeks if we use cord blood, because cord blood has lower number of stem cells. So for those 2 weeks, we have to provide supportive care. This is our transplant unit. The air is HEPA filtered. The children have 1:1 nursing, and we have to protect them from infections. We can't avoid all infections because they have mucositis, inflamed mucous membrane, lot of bacteria in the gut, which will try to get into the blood, and there are no neutrophils to protect them. So infections are the biggest problem in transplant, and all of you know that we are seeing a rise in multi-drug resistant bacterial infections in our hospital. So if we have to have a child with a WBC count of 0 for 2 weeks, that itself is a big challenge these days. If it's 3 weeks and 4 weeks, it becomes next to impossible. So that's why the use of cord has come down, because we are unable to provide the supportive care required for 4 weeks in these children with prolonged neutropenia. So engraftment happens. They need a lot of supportive care till engraftment. And step 6 is a tricky part. Once the new cells have gotten into the body, it's like a proper marriage. The husband has to like the wife has to like the husband. If it doesn't work out, it ends up in a divorce. So rejection and graft versus host disease we prevent by keeping the children on immunosuppression. The difference between bone marrow hematopoietic stem cell transplant and other transplants is that we don't have to give lifelong immunosuppression. The new immune system takes over in about 6 months to 1 year, and they come off immunosuppression, and we give them all their vaccines. Long-term follow-up is important because we've given high-dose chemotherapy and radiotherapy. We watch their growth, we vaccinate them and provide support. So that is the journey of transplant. What is the role of cord blood stem cell? Is it hope or hype in this journey? So the cord was easy in 2000s because we didn't have the 25 million donor database. It was HLA type, kept in a freezer. As soon as a patient needed cord for transplant, we were able to request the cord unit and use it for transplant. Across all ethnic groups, cords could be stored for patients from India, for patients from Africa, where the donor database didn't exist. So you can see from 1990s to 2000, there was an increase in cord blood banking. There was an annual increase in cord blood transplants. Nearly 10,000 transplants were done, unrelated transplants. And we understood that the cell dose was very important. We needed at least 5 into 10 power 7 nucleated cells in the cord unit per kg of the patient's body weight. So if my patient was 10 kg, one cord unit may be enough. But if they were 50 kg, the number of cells in that unit may not be enough. And we have to bear in mind, when we defrost the cord, we may lose about 1/4 of the cells because of the processing. So we always have to aim for extra so that we don't lose enough cells. If we don't have enough stem cells, they won't engraft. So you have removed their existing bone marrow by giving chemotherapy, radiotherapy. If the start functioning, it's a nightmare because the patient is in aplastic anemia state, and that is potentially lethal condition. So we need good matching and good cell dose for using cord unit. So there was a lot of hope in the 2000. We joined the bandwagon and we were able to do India's first unrelated cord in 2007. So it was a little boy who came from Uganda. His mother had already lost a child to Fanconi, and he didn't have any sibling donors. At that time, we didn't have matched unrelated donor registries in India, and we found cord units matched in New York. So that was brought here and transplanted, and here he is leading a normal life, and this year he's finished college and ready to start working. So this is our sibling program, where the first child had thalassemia major. The baby was found to be Thal negative. We harvested the cord and stored. But in the sibling program, we always found that the cells in the cord were not enough for engraftment. There was suboptimal cell count. So we always use the cord and the bone marrow, and this way the donor did not have to give huge amounts. The child was 8 years old. The donor baby was only 8 kg. So because we had the cord, the amount of marrow we needed to take was lower. This little boy came from Sri Lanka. He was a bubble baby with primary immune deficiency. And we transplanted him in 2011. And here he is. I met him last October, and he's studying in class 4. So as an infant, he had come to us, and now he's a class 4 student leading a normal life. Some families are going to the extent of doing pre-implantation genetic diagnosis, getting HLA matched sibling implanted into the uterus. And we've used savior siblings as well. So we've had one transplant where the mother went to Chicago for PGD, had twins, and both of them were HLA matched. So the girl was 13 years old. So we used the cord and some marrow to make up for the 13-year-old girl. So this is data from India. We've done about 120 cords so far, predominantly unrelated and some sibling. All of the sibling cords had a marrow top-up. And the stem cell numbers were inadequate in most units if we used only cord in the sibling marrow program. What about the hype? We are prone to exaggeration. We are human beings. So the whole story of storing cord blood bank for no reason, we are now counseling against storage. It's only used for hematological conditions. So if there's no family history of thalassemia or leukemia, there is no point in storing the cord blood. We get this scenario every day. Children have a hematological condition. They have stored their cord unit in the cord bank with MPS. So they have a cord bank stored. But we try to tell them the child has a blood problem. So if we use the stem cells which are defective, it won't work. But the cord bank has told them there is a family bank and another cord unit can be given free of cost, and there's a fully matched cord. But I did tell you that today, with the menace of superbugs, we are not able to use cord stem cells in India and keep the children neutropenic. The 100-day mortality is as high as 44%, which is unacceptable these days. So we've stopped the cord program altogether. Cord for regenerative medicine is complete hype for cerebral palsy, for autism, Down syndrome, paraplegia. Still, we don't have evidence that it works, and it can only be done in the clinical trial setting. Some occasional reports have come where the cord unit has been the source of a malignancy. If it's an adult donor, there is a long follow-up. So if the donor is 25, we have 25 years follow-up. Donor is 30 years, or even if it's a sibling donor, 8 years, 9 years. But in cord, there is not yet follow-up on the baby. So if there are genetic issues, they are yet uncovered. So there is an ethical point of whether we are using a good cord or not. So what would you do? Would you bank or not bank? What should we tell our patient families? Cord blood banking was very popular worldwide. This is data from 2013. There are two types of cord banks, private and public. Private, I pay money and I keep it for myself. Public, I have donated for use for someone else. And the unrelated transplants we do from public cords. Public cords have very high standards. Stem cell doses have to be adequate, and the rigorous standards are not applied for private banks. Even if there is minuscule amount of stem cells, they are stored. Private banks are for profit, and most public banks are not for profit. And the hybrid ones are actually not legal. So you can't compare apples and oranges. So private banking at the moment, only if there is a sibling who has a hematological disorder, we are recommending cord storage. We now have induced pluripotential stem cells, because the mainstay of cord blood banks is this is a biological waste. If you lose the opportunity, you will never get stem cells. But we have other ways of getting pluripotential stem cells. We have induced pluripotential stem cells, so we can safely let go of that cord unit. Haploidentical transplant, as you can see here, is completely taken over the scenario here. Cord is slowly on its way out, and it's almost on its way out in India. And some units abroad still use cord as a source, but we have moved over completely to haploidentical transplants. So I'll end with some recommendations and say that we wouldn't recommend private banking for healthy families. We have to tell our families that cord blood stem cells are not embryonal stem cells. They are not totipotential and are not the answer to all ailments. And in a selected sibling cord program for patients with thalassemia major or leukemia, it can be beneficial. And our main thing is the ability to adapt to change. IAP with Dr. Anupam Sachdeva has got guidelines, and even the American College of Obstetrics and Gynecology has made a statement to say routine use of private cord banking is not supported by available evidence. So these are some of the references to say that times have changed and we have to adapt to change and make sure that our families don't put in valuable money on cord blood banking at the moment. So I'll end by saying, stay safe. We were giving the gift of cord blood to our children earlier, but now we have to make sure that we all wear masks and stay safe, and do our very best to prevent thalassemia, new births of thalassemia major in our country. And just looking at indices, we can do that and make India thalassemia free. Thank you.
Thank you, ma'am. Thank you for a wonderful presentation. Not only about the cord blood banking aspect, I think you also told the audience about what a transplant is. So, I think that set the stage to explain whether really cord blood is going to help them or not. So thank you for that. Ma'am, there are some questions, and I think before we move on to the miscellaneous hematology aspect, which is a little different from the cord blood banking, ma'am, I think we can do a couple of questions about the cord blood banking aspect. So, your talk was very clear, but still for the audience, I want you to answer this question, that a mother comes to the pediatrician. She's been showing her first baby, and the baby's vaccination, immunization, everything has been going well. She's pregnant. She's got a lot of money. She says, I want to store my baby's cord blood stem cells. The doctor has told me, the company has told me that we can save 80-90 diseases. We can save the child from 80-90 diseases by using this cord blood. How do you counsel that mother? Like, as in live, how would you counsel this mother?
So with the evidence so far, I go on to say that the cord blood was a very good source of stem cells for blood disorders in the early 2000 and in the late 2000. And we could cure diseases, blood diseases, only blood-related disorders like thalassemia, sickle cell anemia, and leukemia. But even there, it wasn't, the promise of cord blood wasn't as great as what we are seeing at the current moment with other technology. And if she does have lots of money and she wants to spend it, there are other gifts she can give to her child. And there isn't really any role for private banking in this day and age. And if she's worried that we would lose the potential source of stem cells, then I would explain that there are other sources of stem cells coming up. Just from our skin fibroblasts, we can make pluripotential stem cells. So there isn't any need for cord blood without a family history of any blood-related disorders. And certainly what they advertise for cardiac problems, neurological problems, there is no proven benefit at all, and it's still like a Robin Hook point.
Yeah. Ma'am, one of the questions that has been asked by Dr. Hema Mittal, she is one of the members of our North Delhi IAP. She's asked, besides KID, what are the other immunodeficiency disorders where there is role and experience with BMT?
Almost all the primary immune deficiency disorders, which is for all forms of severe combined immune deficiency, neutrophil disorders like chronic granulomatous.
I think madam's audio is not very clear. Madam's audio is not very... So we can't hear you, ma'am, but
I'll ask some connection issue.
Yeah, there is some...
Anyone of us else can answer this?
Diseases like IL-10 receptor. Am I audible now? Can you hear me now? Can you hear me now?
It is a bit better, yes, ma'am.
Yeah, please tell me.
So the disorders that you named, I could hear only a few: Wiskott-Aldrich, leukocyte adhesion defect, chronic granulomatous disease, severe congenital neutropenia that doesn't respond to GCSF. Any other important ones you want to add?
No, I said that.
So I think maybe we can take the question at the end, because madam's audio is not very clear. Madam's audio is not very clear. Maybe we can take it at the end.
Okay. Okay. I don't know if you're able to hear me. Should I continue talking or should I stop? I didn't hear that bit. Yeah.
Because it was
No, I think the spectrum of immune deficiency is increasing, is what I'm saying, and most of the primary immune deficiency are now amenable to treatment. If there is history of cancer in the family, and because of that they want to do banking, the answer is no, and definitely not for disorders like autism. Yeah.
Ma'am has answered both the questions that have been taken live. No for autism, no for a family history of breast cancer. And ma'am, somebody has asked what is the cost of the various options. So what is the rough cost of cord blood banking? Would you know that?
Yeah, on average, actually, if you add up, the cost of cord banking comes to around about 75,000, anywhere between 50 to 75. So they give very nice little packages to say initially you have to pay only so much, then it's only so little per year. But the little per year is for because we have to continue topping up the liquid nitrogen. But again, whatever the amount is, that it is now it's now a technology that is going out of fashion for different reasons. So if they're trying to convince people to go for private cord blood banking, definitely it is not worth our while. So if we care for the family, it's best to say private cord banking is not to be recommended,
Yes, ma'am.
except in selected cases. Yeah.
There's another question. Would you do a BMT in chronic, in common variable immunodeficiency?
Yeah, so this is an up and coming indication for transplant, common variable immune deficiency and X-linked A gamma globulinemia, because the burden of continuing IVIG long term in our country is too high, and as the child grows, it's very difficult to cope up with the expenses of IVIG. So if there is an optimal donor available, yes.
And the last question is for hyper IgE syndrome, would you do?
Yeah, again, hyper IgE we thought was not something that responded to transplant, but we've done hyper IgE, and one of those children, it was so amazing, he was covered in warts, and as soon as he got his graft, all the warts just disappeared, and he was so happy because for the first time he could see his results are pretty dramatic.
And ma'am, somebody has asked about the cost of doing a transplant. If that would be the last question. Yes.
Okay, so this is a very blanket question from people. What is the outcome of transplant? How much does it cost? Actually, for us as transplanters, it's very difficult to answer because I showed you about the thalassemia major child. So if you have a small baby, for example, 2 years with a fully matched twin, then the cost of transplant we could do in round about 12 lakh Indian. So you saw the other boy who was heavily iron overloaded, and he is what we would call a class 3 thalassemia, and his transplant can be upwards of 20 lakhs even if he has a fully matched sibling. So roughly sibling allografts cost between 12 and 15 lakhs, and unrelated or half-matched transplants will come in the range of 25 to 30 lakhs, approximately.
Thank you, ma'am. Thank you for answering all the questions. We will now move on to the next session, which is going to highlight the miscellaneous hematology aspects. Dr. Anupam was going to be here, but I think for some reason he's not able to join. He's not feeling well. Ma'am, if you could also stay for the session, if you are free, it would
I can stay.
It would be great to have you with us. So for the next session, we have Professor Deepak Bansal. Professor Deepak Bansal is professor in pediatric hematology and oncology at PGI Chandigarh. Sir is a very, very senior and a very helpful member of the pediatric hematology oncology team. The best part about him is that, the way he teaches, explains, and talks, he makes very complicated matters also simple. So we are really looking forward to talking about some complicated aspects which even hematologists, sometimes feel nervous when we get in our outpatients as to, we have somebody with a 50,000 eosinophil count. What are we going to do? So, he's probably going to make these topics look a little simple. We also have Dr. Shirisha Rani. Dr. Shirisha Rani is a senior pediatric hematologist, oncologist at Rainbow Hospital, Hyderabad. Dr. Deepak, Dr. Shirisha, myself, and if Dr. Revati can also join, we can move on to the next session of miscellaneous hemat.
Thank you, Manas. Nice words. And hello, Shirisha. How are you? And hello, Dr. Revati. That was a great talk. It's so we'll be pulling you up on various cell questions now. And so so am I audible well?
Yes, you're very well audible. Yeah.
Right. So so this is a panel discussion on as Dr. Manas said, on miscellaneous hematology. So it's a very casual sort of a presentation, and you can all relax, and we'll be taking up the questions as if the patient is in the OPD and just a regular case scenario. So panelist Shirisha, Manas, Dr. Revati, and I shall be moderating. So first of all, we'll start with Manas, and we'll talk about eosinophilia. So we do see it off and on, but sometimes it is hard to know what exactly is eosinophilia. So Dr. Manas, would you tell us what eosinophilia exactly means?
So the definition of eosinophilia is when we have an absolute eosinophil count of more than 500. So if somebody has a high eosinophil count above 500, then it is usually called eosinophilia.
Right. So that's great. So absolute eosinophil count more than 500. So whenever there is eosinophilia, there are three things that one has to remember. One is eosinophilia. The second thing is hypereosinophilia. So Manas, would you tell us what is hypereosinophilia?
So when the eosinophil count is more than 1500, that is a time when we start worrying a little more, and that is what is called hypereosinophilia by definition.
Right. Sure. So just to summarize, as Manas said, eosinophilia is more than 500 and hypereosinophilia is more than 1500. So these are the things to remember. But while sitting in the OPD, sometimes we actually forget how to measure the absolute eosinophil count. So it's very simple, just like the neutrophil count. You see the WBC and you see the eosinophil percentage. And like suppose example, the WBC count is 8,200 and the eosinophil is 7%. And while sitting in the OPD, we might actually wonder whether this is eosinophilia or not. So just multiply and divide by 100 and it is 574. So 574 is more than 500. So it actually becomes eosinophilia. So for all of us to remember in the OPD, eosinophil more than 500 is eosinophilia and hypereosinophilia is more than 1500. So we move ahead. And so the third thing that we have to talk about is what is hypereosinophilic syndrome. And that is a thing wherein things really start turning hot. So, Dr. Revati, would you be able to answer offhand as to how do we decide how is a hypereosinophilia different from the rest?
Okay, I think you've put me on the spot. So
Yeah,
if you
I'm
have the
really
definite
sorry.
slide, please add. Okay.
Sure.
So I think the main definition is by looking at consecutive. Okay. I think the consecutive sampling, and at 6 weeks interval, if we have eosinophilia persisting and evidence of eosinophilia affects, that's what we call as hypereosinophilic syndrome.
Sure. Yeah.
It's simple.
Yeah.
So
Yeah,
it has to be
absolutely.
persistent, and eosinophils have tissue infiltration and cause problems in, and the commonest involved in eosinophilia will be the lungs.
Right. I'm actually sorry. This was meant for Shirisha. So Shirisha, would you want to add here, please?
Yeah, so as Madam mentioned, the hypereosinophilia syndrome is like eosinophil count of more than 1500 done at minimum of 4 weeks apart over a period of 6 months if you are observing without any explainable causes, like unexplainable eosinophilia persisting for a period of 6 months with organ infiltration, as Dr. Revati ma'am just mentioned, organ infiltration. It can be CNS, heart, bone marrow system, liver, or lungs. So infiltrating the deep organs, then it is called as hypereosinophilic syndrome.
Right. So as you said, so absolute eosinophil count more than 1500, on 2 occasions more than 1 month apart, plus organ dysfunction. So in any child coming to the OPD who has eosinophilia, we have to think or investigate for organ dysfunction after ruling out the common causes. So, so now we need to talk about the common causes of eosinophilia in outpatients. So Manas, would you want to take this up?
Sir, whenever we look at the causes of eosinophilia, whenever we read the Western literature, it will mainly be the first one would be allergies. But somehow I feel that allergies are not that common in India as compared to what we see in the Western population. Here, still the more common problems are infections. So I feel that, infection should be the first reason why eosinophilia is there in the patients. Now, infections are mainly that can cause eosinophilia would be parasitic infections. We can have ascariasis, filariasis. They mention about trichinella. They mention about toxocara and all these strongyloides. All these parasitic infections can lead to eosinophilia. Then there are some bacterial infections and viral infections as well, which can lead to high eosinophil count. Like in HIV, you see high eosinophil count. You can see high eosinophils in tuberculosis. A lot of allergic disorders, urticaria, atopic dermatitis, these are commonly associated with eosinophilia. Asthma is associated with eosinophilia. Then gut disorders like inflammatory bowel disease, that can be associated with eosinophilia. You can have rheumatic disorders like rheumatoid arthritis, Churg-Strauss syndrome. These can be associated with eosinophilia. Sometimes malignancy can present with eosinophilia like Hodgkin lymphoma, ALL, AML. And then comes the category of these clonal eosinophilic disorders. So like a clonal eosinophilic leukemia, which is very rare, but at the same time you can have there are certain mutations present in individuals which can predispose a patient to have a lot of eosinophil count, and I think I'm sure we are going to talk about those mutations as well. And more or less these are the broad categories. I'm sure there are many other causes that I have missed, but this is what just comes to my mind when you ask me about when you see a lot of eosinophils in patients.
Yeah, sure, Manas. I think you've already covered more than required for the regular causes of eosinophilia while sitting in the OPD. And just to summarize, so as you said, allergic disorders. So specifically allergic rhinitis, which is fairly common in children, and drugs. We tend to miss the drugs, but again, not very common in every OPD. So drugs, have to remember, you've already covered the helminthes, so all the various parasites. I think one important thing is scabies. So this I found yesterday while preparing this talk, and scabies is something that we might miss in the OPD. And of course, this we might think of asthma, but then ABPA is the close one. So whenever we think of asthma, and if there is a lot of eosinophilia, one has to keep in mind the ABPA and then a lot of viral infections. So these are the common ones. So so this is a voting. I'll request all the participants to vote for this. So the average national prevalence of soil transmitted helminthes in India as per 2010 data is how much? So you have to choose between A, B, C, D. You have the choices in front of you.
So there is some data like that as well. That's interesting.
Correct. Yes. So there are a lot of publications on prevalence of parasites in the stool. It's been like in children, in adults, rural, urban. So there is data all over India. In fact, in the entire world as to what is the prevalence of worms in the stool. So this is it. So I guess we can, yeah. So now we have the answers here. So I think most of about 40, half the people have got it right, and the rest half are close as well. So it's about 20 to 50%. So that's a fairly huge number, which means that if you see any child, there are about 1/5 chances that he would have some kind of worms. But if we move ahead, so when we say soil transmitted helminthes, it means either a round worm or a hookworm or a Trichuris trichura or the whipworm. So, these are some individual studies which have shown, like from Vellore, they have shown that rural was about 9% and urban is about 5%. From Lucknow, it's about 20% and urban is about 5%. So it depends whether it's rural, urban, or what kind of population that one is. Just to show that the numbers are fairly high, although they are decreasing with time now. So this is another question for the audience, please. So what is the prevalence of allergic rhinitis? That's number one. And number two, of V's. in children in India in the age group of 6 to 7 years. So these are relatively recent studies. So they have looked at overall prevalence of allergic rhinitis and V's. Because these would both cause eosinophilia. So while sitting in the OPD, one, it's so common disorders. So about 10 seconds for everybody. I think we can see the answers now.
I think, it says how many people have voted.
Oh, okay. Right. So most have marked B, but the correct answer is C, 11% and 7%, which means that the prevalence of allergic rhinitis is 11 and that of V's is about 7%. So more or less close answers. So just to give you an idea about the common disorders prevalent in the population. So I'll move ahead. Right. So, and then drugs. So the common ones are cephalosporins, even ranitidine, which could be commonly prescribed, can cause eosinophilia, and more commonly the phenytoin and carbamazepine. So these are the drugs which can cause eosinophilia with this so-called the DRESS, or the drug reaction with eosinophilia and systemic symptoms. So phenytoin and carbamazepine, fairly commonly used, can cause eosinophilia. And as Manas had already said, rarely one can have neoplastic disorder. So if you have a child with eosinophilia with hepatosplenomegaly or lymph nodes or something, not looking the straightforward OPD case, one has to actually consider doing a bone marrow examination to rule out leukemias and lymphomas, because leukemia could be underlying eosinophilia, not common, rare. And then these are the things that one has to learn, that underlying an eosinophilia, there could be immunodeficiency or autoimmune disorders. So we'll talk about it more this thing. So Manas, again, will continue with you. Relevant history and examination in a child with eosinophilia. You've already told us what are the causes. So very briefly, can you tell us, when a child walks into your OPD and he's got a report of eosinophilia, what would you like to ask and examine?
So I'll probably make up the history from the causes that I mentioned. So I would ask history about allergies. I would ask history about asthma. I will ask history about skin problems. That would be my first thing. Then I'll ask history about passing worm in the stools, which may not be there in most of the children infested with worms. But I'll ask for a history of pica, because if you have a history of pica, there are good chances that you also have worm infestation. I'll ask history about chronic diarrhea, because IBD can be like that. I'll ask history about joint swellings, joint pains, any swellings in the body like lymph nodes or anything that has been seen. Then I'll also ask history about eosinophils causing problem. So, sometimes eosinophil infiltrate the organs and cause problems. So like lung issues, there can be heart issues, there can be CNS related issues. So, if somebody comes with a 40,000-50,000 eosinophil count, I'm going to just make sure that by history, he doesn't have a cardiac involvement and he's not having exertional breathlessness. That will point towards the fact that, the eosinophils are causing an organ damage in this person.
Sure. So you've covered everything as to,
And
so as per the, depending on the etiology.
If I can just add there, as
Please.
Deepak rightly pointed out that a decade ago, if we saw eosinophilia, the commonest cause would be helminthic infection and allergies. But now more and more, the autoimmune spectrum comes as the main cause of eosinophilia. So even in the chat box, there are questions to say if there's polyserositis, eosinophilia. So there's some child with ascites. Always we have to think of underlying autoimmune disorders, which the body is reacting to them. So eosinophilia is a feature. So autoimmunity is something that we have to look for other than the usual helminthic and allergic component.
Right. So Shirisha, could you, thanks for that, ma'am. And Shirisha, could you tell us the initial investigation in a relatively well child with eosinophilia? So, what are the first line tests?
So the initial investigations, once again, depends on the history, what we got. So initially, like when we are suspecting infections, so more common cause being parasitic infestation, stool routine examination is the most important part. We have to go ahead and do, and that covers a lot of parasitic infestations. If you are suspecting, though it is not common in our part of the country, like schistosomiasis and all, like urine examination also may cleanse the diagnosis for your parasitic infestation. At the same time, when you are suspecting allergic disorders, so for allergic disorders, doing the chest X-ray to see hyperinflation, or looking for even hilar node enlargement for tuberculosis or any other parenchymal lesions for tuberculosis. And also look for thymus in the chest X-ray, which indicates narrow thymus or absent thymus indicates primary immunodeficiency disorders in children, so especially SCID. So going by that, like you also have to look at that shadow, and at the same time also look at the peripheral smear in CBP. All simple investigations: stool, urine, chest X-ray, and CBP. In complete blood picture, I will be looking at WBC and absolute lymphocyte count. If it is less, significantly less, like there are criteria, I think we can discuss that in subsequent slides. So significant lymphopenia also indicates towards SCID. And at the same time, also we can look at the platelet count and size of the platelets, which also gives clue towards things like Wiskott-Aldrich syndrome. And at the same time, if we are suspecting autoimmune disorders, my workup will be towards that, whether it is JRA or whether it is inflammatory bowel, other conditions like autoimmune inflammatory bowel disorders, then my investigations will be towards that. And at the same time, we also have to remember that for all these conditions, if we are not getting diagnosis with the simple investigation, definitely we have to go ahead with the bone marrow examination also, and look for any lymph nodes evidence in the imagings like X-ray or ultrasound.
Sure.
So
Right.
all this will give you clue.
Right. Yeah. Thanks for that, Shirisha. So, I mean, after the initial investigations, oops, my slides are lost. Yeah. After the initial investigations, let's, this is the question which has perplexed me at times, and I will like to ask Dr. Revati if she can, what she feels about this, that should we be, I mean, albendazole is fine. One would definitely give it to a child coming with eosinophilia to the OPD without a second thought, but would you give, hetrazan empirically or antihistaminics for the management of eosinophilia in absolutely well children with a significant level of eosinophilia? You kind of do a first line investigation, you don't find much, and you're tempted to just treat something. So would you give hetrazan? Because this is something which adult medicine people do, and we tend to sort of copy them. So would you agree with this, even in the areas where filariasis is not that common?
So I run a community clinic every Wednesday, and in Tamil Nadu, actually, the filarial infection rates are not low, and you'll be surprised actually, because I do follow the adult protocol, and when we see eosinophilia, give them the deworming, and total course of hetrazan is 6 weeks. So I usually give them a 2-week course and ask them to come back, and you'd find that in about 80-90% of the kids, there is a downward trend in the eosinophil count, and by 6 weeks it comes down to normal. Whether it was something that happened automatically with time or the hetrazan help is difficult to know, but the main thing is it has very little drug interactions and has reasonably good safety profile. So if we are having eosinophil count of 20,000, 30,000, it wouldn't do harm. And for symptom relief, add the antihistamine and montelukast and get them back in 2 weeks, and then decide whether we have to do further investigations. That is, if they looked absolutely well. Obviously, the whole protocol is going to be different if it's a sicker child. So in the well children, yes, it is my practice to give them both anthelmintics and all the things that you have said, hetrazan and antihistamines, and the majority of the children. So if you saw about 100 children, most of them would be okay on this concoction, and you'll only be left with a handful, about 5 or 10, that you have to investigate further.
Thank you, Dr. Revati. So Manas, being in North India, would you agree with giving hetrazan empirically to children with eosinophilia?
We don't have any evidence of giving hetrazan in this non-filarial, endemic community. But I'll just share with you that I trained in Mangalore, so there was a lot of filariasis there. So that area was endemic for this, and I think there, when I was practicing, when I was studying, a lot of children were treated with hetrazan for filariasis, for eosinophilia. So their empirical therapy was being given, but in Delhi we don't find any evidence that hetrazan helps these children. We have used for many And most of the times, actually, what we get is that the children have received hetrazan and then they have come to us, and still the
Right.
eosinophil is a lot. So I won't be really able to tell how many got benefited, but we see plenty of children who have received hetrazan and then they come to us.
Yeah, so I think that's my experience as well. We sometimes give it because others give it, but I'm really not sure if it helps, particularly in non-endemic regions. So we'll move ahead. So this many panelists have already answered that can eosinophilia be organ or life threatening in children? And answer is yes, not very common. So Manas, would you want to just quickly add whatever you have already not said as to how to suspect and investigate organ damage in children with eosinophilia?
So, sir, most important is the heart, because eosinophil produces some chemicals that can damage the heart. We'll not go into the details of pathogenesis, but heart is the main area where the damage can happen. It can cause Loeffler's endocarditis, and that can lead to myocardial dysfunction, and the children can be very sick because of that. The other problems can be angioedema, extensive urticaria. Children can have like anaphylaxis and airway obstruction. Some of the kids can have CNS issues with altered sensorium, encephalopathy, thrombotic episodes because of high eosinophil count, and some children can have lung issues because of the high eosinophil count. So the moment we see very, very high eosinophil count, we are worried about these 3-4 organs, and we want to immediately do something for these kids to save them from the catastrophe.
Sure. So just to summarize, it's the organ damage in patients with hypereosinophilia which makes us worry about eosinophilia in otherwise children who seem to be so well. So just to summarize, one needs to do all these liver enzymes, creatine kinase, renal functions, and troponin, as Manas has said, ECG and echo for the heart, pulmonary function, chests, chest axis, CT and CT abdomen, depending on the clinical listing, and tissue biopsies in case one wants to demonstrate tissue invasion with eosinophils for the diagnosis of hypereosinophilic syndrome. So this would not be for a typical OPD patient of eosinophilia. It's only when there is some clinical or lab evidence of organ damage. So Shirisha, this is for you. And we have a immunodeficiency sort of full immunology unit, and they are very crazy about this. So what are the immunodeficiency disorders that we have to suspect when we see eosinophilia?
So we all know that eosinophilia can be one of the indicators for some of the underlying immunodeficiency disorders. Among them, one is like hyper IgE syndrome, humoral immunodeficiency disorders like hyper IgE syndrome, or combined immunodeficiency disorders like Omen syndrome, or even ADA deficiency, PNP deficiency also can have eosinophilia, and other autoimmune lymphoproliferative syndrome, that also the variant of immunodeficiency disorder, also can have high eosinophil count. And at the same time, conditions like Cosman also can have eosinophilia. And syndromic associations with immunodeficiencies like Wiskott-Aldrich syndrome also can have eosinophilia. So these are some of the immunodeficiency disorders associated with high eosinophil count, and most of them are also expected to have eczema along with eosinophilia.
Right. Thanks, Shirisha. So again, not very common, but something that we need to know, particularly hyper IgE, or what is the Job syndrome. So this can be seen in older children, and like with skin changes, recurrent bacterial infections, particularly staph. So if somebody is coming with staph infections and has eosinophilia, one should ask for IgE, because the IgE typically tends to be more than 1,000 in these patients with Job syndrome. So IgE is often elevated with eosinophilia because of allergies or whatever. But if it is really high, more than 1,000, then one has to think of Job syndrome. The other immunodeficiencies which Shirisha has mentioned, these are relatively rare. So like Omen syndrome is typically seen in the neonatal age group, and they would have other features as well to suspect. So I mean, by default, Revati, you're getting the tough ones, but second line investigations in a child with unexplained eosinophilia. So when do you decide that, you need to start asking for those mutations and stuff like that in children with eosinophilia? And how often do you do that in your clinical practice?
So in our, I don't know about Chandigarh, but in our hospital, we run quite a busy benign hematology clinic. But despite that, the need for second line investigations in a child with unexplained eosinophilia, we'd hardly be doing about 2 to 4 children per year. So it's not very common. In adults, myeloproliferative disorders are more common than in children, and especially in the very young, it's rare. So probably in an older child. So we do a bone marrow aspiration and a biopsy to see if there is any fibrosis. So just an aspirate would not be enough. So when we do a marrow, we'll also send the sample for driver mutations. What is driving the eosinophilia? So there is these days, because we have good panels for myeloproliferative panel, it could be a symptom, a manifestation of chronic myeloid leukemia. So we would look for BCR-ABL. It could be a presentation of an underlying clonal evolution in hypereosinophilic syndrome. So there is a mutation called PPG, the platelet-derived growth factor. So all the unexplained eosinophilia mutations we could do only in a handful of children. But an aspiration and a biopsy, also look at what organs are involved and get echo done. Definitely a cardiologist opinion, because they have a type of cardiomyopathy which is an obstructive type. So not that they go into failure because of a dilated heart. So it's an obstructive cardiomyopathy which can be reversed with treatment, and we have very good treatment available for all these changes if caught early. What is the lung doing? So HRCT, chest, liver, and spleen and marrow. So these are the main organs we would look. If they had any CNS manifestations, then an MRI brain. So that would be all of the second line investigation. Certainly, I would like uric acid and LDH, because all myeloproliferative disorders, they can have high uric acid, and LDH will give me an idea of whether this is going to be a very rapidly progressing type or not, because a high LDH correlates with the severity of all of the myeloproliferative disorders.
Thank you, Dr. Revati. So, as you have said, so basically what we're talking about here is the hypereosinophilic syndrome and variants that we need to investigate whenever we have hypereosinophilia, and after ruling out the common allergies and the common parasites. So something which is mentioned is a serum B12, which has been shown to be high in the myeloid variant of HES. So whenever there is very raised eosinophil count, and let's say there is hepatomegaly, splenomegaly, then one has to think of hypereosinophilic syndrome and the myeloid variant. So one simple test which really helps is a serum B12, which is elevated in the myeloid variant of HES. And then when one wants to really confirm the diagnosis, then one has to get the genetic test done. And these are what are called the PDGFR and the FGR rearrangements, and these rearrangements. So these are hard to remember, but whenever the eosinophil count is very high and one has hepatosplenomegaly, the B12 level is high, then one can ask for these genetic mutations to confirm what is called as the hypereosinophilic syndrome. And these are the other rare variants of hypereosinophilic syndrome. So the previous one was myeloid variant. So then the second one is a T cell variant, wherein the B12 levels are not elevated. And these are the less common causes of hypereosinophilic syndrome, right? So moving ahead, besides B12, one can also do serum tryptase and IgE levels for monitoring patients of HES. So Manas, for the sake of time, yeah, please.
That clinically, the most difficult kids are the ones that come with florid eczema, and we scratch all the eczematous lesions, it gets infected, they have staph boils there, and they have a very high eosinophil count and very high IgE levels. So it's just eczema which they've come with a flare up, or is it hyper IgE syndrome? And we used to have problems with this for a very long time, but now children, we have the gene mutation available, so that helps differentiate. So I think that group is most challenging to see, are we dealing with a primary immune deficiency, or is it just a child with eczema who's going to grow out of it?
That's very true.
Yeah.
The NGS availability of NGS has made this easy for us, and we are able to differentiate hyper IgE versus those eczemas and atopic dermatitis who get complicated and come to us. So that has really changed the scenario.
Right. Manas, for the sake of time, I'm not going to ask you this question because hypereosinophilic syndrome is not very common. And just briefly, one can use steroids. So imatinib is specifically used in hypereosinophilic syndrome, and that is the reason why it's important to investigate for it and the PDGFR mutations. And if these don't help, the drugs which are mentioned are hydroxyurea, interferon alpha, and if nothing else helps, then one has to go in for a transplant. But the important thing to remember is that imatinib, which is a TKI inhibitor, can be used for hypereosinophilic syndrome. And that's really great because then one does not have to use steroids. So
just say one comment.
Sure, Manas.
Even these hypereosinophilic syndromes, the first line is always steroid. So if they are not responding to that, then addition of imatinib, or you can add imatinib straight away when they have very high eosinophils. But the trial of steroids, most of the time it helps.
Correct. So these are not very common disorders. So even I'm not very sure, but isn't it true, Manas, that if you identify the mutation, then you can go for imatinib and stop the steroids?
I am not very sure, sir, but I think everywhere they say that steroids are the first line. So although I understand that if you have a mutation, using a TKI which will fix that problem makes more sense, but I think empirically all of these children are given steroids to begin with.
Right. So Shirisha, this is for you, and this is a fairly common situation in the OPD. Do you want to ignore eosinophilia while being in the OPD? You have given your hetrazine, you have given your albendazole. There are no obvious allergies. There is no hepatosplenomegaly. There are no mutations. Child is absolutely well running around, but his eosinophil count is very high. So would you give steroids? You would not give steroids. For how long would you continue, or would you just ignore and tell them not to stop doing the CBCs?
So if it is eosinophilia, as we all do by definition, if it is more than 500 in an asymptomatic child, definitely we can follow. But if it is hypereosinophilia, that is more than 1500, definitely we will be looking at controlling the eosinophils. As we know, though the child is asymptomatic now, if we leave them for some time, they are bound to develop, they are bound to be symptomatic. So we have, as madam was saying, we also have a busy hematology clinic there here in Hyderabad, and then we do see a significant number of eosinophilia, hypereosinophilia syndromes over here, and majority of the times we don't find any underlying cause. So for them, if we leave them with hypereosinophilia who is asymptomatic, invariably in a week's time or few weeks time, they come back with the symptoms of fever and other organ infiltration signs. Going by that, we do offer some form of treatment. Definitely, they would have received already deworming and all. Sometimes even hetrazone also would have been tried, but if it has not been tried, then we go ahead with that. If that also not helping, definitely steroids are indicated. But if we are giving, we always go for bone marrow and then make sure that we are not missing malignancies. And start steroids, give for 2 weeks, and then taper over a period of next 2 weeks. In our experience, whenever we taper and then stop within a month, that is at least 2 to 4 weeks time, they tend to again build up the eosinophilia, hypereosinophilia. That's what we noticed. And then you put them on, instead of just steroids, give them steroids. This is for the cases where you don't find any underlying cause. So give them steroids and put them on medications like montelukast and all. Then the eosinophilia will be completely under control. That is what we have noticed in our experience.
Right. Yeah. Thanks, Shrisha. So I think I have struggled with this question.
Multiple episodes, and we end up offering them for longer periods of these montelukast and all.
Right. So I think we have struggled with this question quite a bit, and we've had some patients in our clinic who are well, but who have got very high eosinophil counts. And as you said, we have given them steroids. The moment you taper, it starts rising up again, and then you end up wondering whether you're causing more harm by giving them steroids, or just or is the eosinophils are causing more damage by causing organ damage. So while searching for this, I actually found these two conditions. It's there in up to date. The first thing is called as asymptomatic familial eosinophilia. So I think in all cases of eosinophilia, we must investigate the parents also for a CBC. So this is an autosomal dominant condition, and the solution is observation alone. They do not have any clinical manifestations. They do not have any organ involvement. So I think in all cases of eosinophilia, one must investigate the parents. And the second thing is actually something called as hypereosinophilia of unknown significance. And the name is self-explanatory. They are asymptomatic. They have marked eosinophilia, and there are no clinical manifestations or organ involvement, and one is supposed to leave them alone. So there are actually sort of safe, pockets available where we can hide ourselves to say that, look, we will leave this child alone, and maybe we don't need to treat provided the child is asymptomatic. So Dr. Revati, I don't know whether you will agree with this, that you may want to leave some children with eosinophilia or hypereosinophilia if they're absolutely asymptomatic.
Yeah, absolutely. I have about 3 on follow-up, and they run an eosinophil count of between 2,000 and 4,000, and they've been asymptomatic for several years now. It hasn't come down, but nothing's, it's on the downward trend, so we just keep an eye on them. That's all. Yeah.
Sure.
Because
So
by
just
giving long-term steroids, there's more damage done. So we have to limit the use of steroids if they are asymptomatic. Only if the eosinophils are showing any propensity for organ involvement, or then we need to treat them. Otherwise, just eosinophilia, we can watch.
right. Thank you. So this is the voting for the audience. So all of the following are indicated in a child with unexplained hypereosinophilia, except, so you have to choose between A, B, C, D, folate, B12, bone marrow, or parent CBC. So what is not to be done in patients with hypereosinophilia? So this is just to see if everybody is awake and able to listen and tolerate us. Right, so maybe we can have the answer now. Right, so everybody has, most of people have got it right. It's folate, it's just a trick question. One is supposed to do the B12 levels, and folate has really got nothing to do with hypereosinophilia. So we move ahead. Right, so I think we've covered this, that these are the common causes of eosinophilia, but one has to remember hypereosinophilic syndrome and the mutations and immunodeficiency. But then there could be some rare cases as well, which are well and one need not do anything. So we quickly now go to lymphocytopenia in infants and older children, because this is also important. Shirisha, would you be able to often answer what is the definition of lymphocytopenia in infants and older children? I'm really sorry for putting you on the spot, but it's the numbers are sometimes hard to remember, but
no
still.
problem. So basically, to know, to call it as lymphocytopenia, we also should know the pattern of lymphocytes in the children. Like in early neonatal period, if you leave early neonatal period, from later part of neonatal period up to 5 years, it is always lymphocytic predominance. That's why we see more of lymphocytes. But if you have a lymphocyte, to call it as lymphocytopenia, less than 2,500 absolute lymphocyte count, you define it as lymphocytopenia. If it is less than 1,500, then things like severe combined immunodeficiency are strongly suspect.
Right. Thanks, Shirisha. So I always find it very difficult to remember, but the numbers are actually quite varying, and the age cutoff one is mentioned is less than 8 months of age. So if it is less than 8 months of age, any ALC less than 4,500, and for older children that is above 1 year of age, it is less than 1,500. So again, absolute lymphocyte count is calculated just like you calculate absolute neutrophil count. For example, if the WBC count is 8,200 and the lymphocyte count is 45%, this is 45%. So 8,200 multiplied by 45 divided by 100, you get a value of 3690. So if this is a 2 months old child, this is actually lymphopenia. So whereas if he's above 1 year of age, it's actually normal. So look at the difference, look at the wide range. So below 8 months is 4,500, and above 1 year it is 1,500. So one has to multiply the WBC with the lymphocyte percentage and divide by 100, and really try to remember these numbers, because they really have a lot of significance as far as the etiology of lymphocytopenia is concerned. So when I looked at this, I also thought, let me look at the normal values of WBC count and percentage neutrophil count in neonates and children over the age. So we are pediatricians and we are supposed to know this. But you know what, when I looked at the numbers, it was actually quite surprising for me. So very briefly, I will describe this table. This is from birth till 1 month. So this is the WBC count, this is the absolute neutrophil count, and this is the neutrophil percentage. These are the sort of the normal range which are mentioned. So as soon as the child is born, the average WBC count is really high. And look at the neutrophil percentage, it's polymorphic. And by 1 week, the WBC drops and the polymorphs also drop to about 45%. And by 1 year of age, the WBC count has dropped down to 11,400, but it's still pretty high. And look at the normal range. It can be from 6,000 to 17,500. And the neutrophils have really dropped from 61 to 31 here. So here the lymphocytic predominance really starts kicking in, as was said by Shirisha. And by 10 years of age, it's more near the adult range. And this is the neutrophil count that you would see. So, when I saw these numbers, I immediately called up our lab hematologist, and I told him that, the Coulter reports that you're giving us, please start giving us the age-based norms as well. And I asked him if it is possible, and he said yes. So they just have to feed in the normative data in their Coulter, and if you put in the age, the normative data would come as well. While sitting in the OPD, we get so used to looking at the normals of the adults that you tend to feel ki haan, theek hai, but if you look at the neutrophil counts and the WPC count, that's really varied throughout the age range, and I think it can be very hard to know what normal is unless one really has a hard figure to compare. So Manas, now back to you, and if you would like to tell us the infections that can result in lymphocytopenia in children.
The commonest infections that lead to lymphopenia are viral infections. So if somebody gets measles, mumps, if somebody gets an influenza virus, and now we are talking about SARS-CoV-2 virus, the COVID-19 virus, that can cause lymphopenia. So all these are the common things that can cause lymphopenia in children. Then there can be typhoid, tuberculosis, which can cause lymphopenia. I would say sometimes fungal infections can also lead to lymphopenia, like histoplasma and others. So, these would be the common causes where you can see lymphopenia in children.
Sure. So I think as Manas has said, that corona is the one that we can talk about right now as a cause of lymphocytopenia. And so Shirisha, this is for you. And again, our unit, the immunology unit, they keep on emphasizing this repeatedly, that lymphopenia is often the first clue to diagnosing SCID. So please, if you would like to elaborate this, because as to what should be the number that one should look at in infants at the lymphocyte count, and what has this lymphopenia got to do with SCID?
So as we know, majority of the times SCID present in less than 1 year age group. So going by that, like, if the lymphocyte count is less than 2,500, then definitely we have to strongly suspect. If it is less than 1,500 or less than 1,000, it is almost a hallmark of SCID, severe combined immunodeficiency disorder, especially in conditions like ADA deficiency or PNP deficiency, where lymphopenia is prominent. However, in having said that, we also should remember that not all the cases will have lymphopenia. Some of them can have even normal lymphocyte count for that age, or there may be even lymphocytosis also. So, in fact, I would like to share here that whenever we look at the differential count in the CPP, as you mentioned, we should always look at the age-related norms as well as differential count carefully, because of a couple of kids who got admitted with the severe pneumonia, which was ongoing for 2 to 3 weeks at early infancy in our hospital, our pathologist alerted us because consistently the lymphocyte absolute percentage of lymphocyte was coming less than 5%. So even like, we should be like sensitized towards looking at the differential count carefully.
Right. Okay. Thanks, Shrisha. So I think we are really running short of time. So I'll try to just quick up here. So if there is isolated persistent lymphocytopenia, one can ignore if there are no associated findings. But if it is persistent and with these findings of mouth sores, history of infections, one has to immediately evaluate for immunodeficiency, as Shrisha has said. So again, this is a voting question. So this is the diagnostic criteria for SCID. Includes all except. The first is male or female patient less than 2 years of age. B is male patient less than 3 years. Third is less than 20% T cells. And fourth is ALC, absolute lymphocyte count less than 3,000. So this is the relevant to diagnostic criteria for SCID.
So while people are voting, I would just like to comment that we recently had one child whom we almost diagnosed as SCID, but later on turned out to have a RSV infection, which led to severe lymphopenia in the child. And as the RSV went away, the lymphocyte count also improved. So the child had, all the T cell, B cell, everything was in the boots. We thought it is a SCID in a young child, but actually it was just a virus leading to that severe lymphopenia.
Yeah, I totally agree with you. With the but thanks to the genetic tests which are available now, one can at least confirm. Right. So most of the people have got it right. It both. Yeah. So males and females both can have SCID. It's not just X-linked. It could be autosomal recessive as well. So yeah.
I think while they were wanted to say that it's all good practice. All the modern machines that do CBCs, there's something flagging. So if for the right age it's is entered, then neutrophilic. If I think twice a month the machine will flag to say that there is penia. For example, if it is COVID, the hallmark is eosinopenia. If you see zero eosinophils, you won't think of COVID. So all of the there'll be a star or either a plus if it is high or a minus. So if, always take a minute to look at the machine out so that you will know what cells are less, what are low, what is abnormal, and that will help with your clinical decision.
Yeah, absolutely. Thank you. So this is about the specific diagnosis of SCID, and I think one can read up as to how to diagnose SCID. Once we have lymphocytopenia, then one can do the lymphocyte subpopulation by flow cytometer, and then get in the team involved and do the specific genetic tests. And then it could be probable or it could be specific. In probable, again, the number which one I think should remember is then absolute lymphocyte count less than 3,000. So that is the thing that one should always remember, because if you remember this ALC less than 3,000, you will not forget to suspect or diagnose a SCID. So Shirisha, would you like to take this up? Sometimes we get patients and they have a lot of 80%, 90% lymphocytes, but as soon as they come to the hospital, they will immediately diagnose them as blasts. So why is it that many times outside it is reported as lymphocytosis, but the moment they land up in the hospital, they become blasts? So how to distinguish between lymphocytosis and blasts on peripheral smear?
So one is like clinical history, as well as looking at the other cell lines in the peripheral smear. So looking at hemoglobin as well as platelets. So hemoglobin, platelets are fine. Morphology of the lymphocyte is normal, or it is heterogeneous. Sometimes with viral infection you have lymphocytosis, but they do look atypical, but the appearance of the cells are heterogeneous in appearance. Then you do think that they are more of reactive cells in the presence of normal hemoglobin, normal platelet count, or and clinical suspicion is low, but you have lymphocytosis and few reactive cells are atypical cells in the peripheral smear. You do take it as possibly secondary to infection. But if the same lymphocytosis is having a large cell, which is almost 1.5 to 2 times of your regular lymphocyte or RBC size, with scanty cytoplasm, dense chromatin, and homogeneous in appearance. Most of the lymphocytes are large, abnormal, and also homogeneous in appearance. Then you would like to go ahead with the bone marrow examination, taking that possibly this is a blast. And one is like sensitize. Why outside lymphocytosis becomes blast? One is like sensitization towards recognizing the cell is one thing. And of course, having more insight into examining the smears and all is another thing. That is how we can distinguish.
Sure. I think if I'm sitting in the OPD and if I get a child who's having 80-90% lymphocytosis with liver and spleen, and as you said, thrombocytopenia, I would think that it is more likely to be leukemia. And sometimes it is hard to call them as blast, because the moment you call them as blast, you're labeling the child to have leukemia. So I think it is just an apprehension at times, and the pathologist might even know that these are blasts, but she or she might be apprehensive in actually calling them as blast. So one can distinguish by morphology, and of course, if there is a doubt, one would do a flow cytometry, and one would immediately know whether these are blasts or whether these are lymphocytes. So Manas, quickly, what is the normal platelet count in a child, and what is the definition of thrombocytosis?
So normal platelet count is from 1.5 to 4.5 lakhs. So if you have above 450,000, then it is thrombocytosis.
Right. So thankfully, there are no ifs and buts here. There's nothing to do with the age. Thankfully, nothing to do with the neonates as well, and nothing to do with the child and adult. And it's very, very simple, 1.5 to 4.5 lakhs, and anything more than 4.5 lakhs is thrombocytosis. So Shirisha, can you quickly tell us what are the common causes of thrombocytosis? I think it is a common thing that we see in a Coulter report with the platelet count being high. So what are the causes that one should remember in everyday practice for thrombocytosis?
Yes, it's one of the common problem we all encounter in our everyday practice, I should say. So in that, like first is like infections. Any infection can trigger, it's a raise in platelet count is like, body response. So reactive response. So you can have thrombocytosis secondary to infection, or it can be secondary to iron deficiency anemia. If you have low hemoglobin, EPO, erythropoietin, will definitely get stimulated, and then it shares the structural similarity with TPO. which can trigger the megakaryocytes and produces more platelets. So that also can result in thrombocytosis. And on the other hand, we do get referrals that, child had severe wheezing and we have given hydrocortisone and there is a rise in the WBC as well as rise in platelets. And that is how we do get, at times we all might have encountered. So those kind of referrals. So medications like steroids also will trigger more of thrombocytosis, which we also notice in our clinical practice when we are following ITP kids when they come in the follow-up after initial response. And other causes of thrombocytosis, like if you come to malignancies, and of course, before malignancies, we also have to remember autoimmune conditions like juvenile idiopathic arthritis, that also can have thrombocytosis. And inflammatory conditions like Kawasaki, autoimmune or inflammatory conditions like Kawasaki disease also can have thrombocytosis. And well, last but not least, malignancies, chronic myeloid leukemia, and hepatoblastoma, they can have thrombocytosis. And early stage neuroblastoma also can have thrombocytosis to begin with.
Right. So there are a host of conditions, and Shreesh has already told them. I think most of us do know that iron deficiency causes thrombocytosis, and with low hemoglobin, low MCV, and a raised platelet count, it's a very easy way of making a diagnosis of iron deficiency, and one need not ask for serum ferritin and fancy investigations, and one can just treat on the basis of a Coulter report. And these are the other common sort of inflammatory conditions which can cause thrombocytosis. Celiac disease was one interesting one which I found, and nephrotic syndrome as well. Kawasaki is something that we are all aware can cause thrombocytosis, and hemolysis as well. So Manas, this is for you. What is the definition of so changing gears here, definition of a leukemoid reaction and common causes of leukemoid reaction in children?
So a leukemoid reaction would be a very high white cell count, a lot of neutrophils, mainly mature neutrophils. Usually the white cell count is more than 50,000 in this situation. And, when you see that kind of a mature neutrophilic response to some kind of an infection with a very high white cell count, you call it as a leukemoid reaction.
Right,
the common
thanks.
causes
Yeah.
are mainly infections. You can have Shigella infection, you can have Clostridial infection. So these are some common infections that can trigger a sudden high white cell count, and the child can present with that.
Right. So I think this used to be a fancy stuff in the past when things were more difficult, but now things have become easier. So any white cell count more than 50,000 and more mature with sort of, little bit of left foot shift as well. And these are the specific etiologies of a leukemoid reaction. And I think these are more like an MCQs type of questions for some kind of a MBBS or MD entrance exams, that you have very specific infections which can cause leukemoid reaction. And as you can see, and of course, all patients of thalassemia who have had splenectomy, they have raised WBC counts as well. Right. So I think this is just a few more slides and some more fun slides. So this is a fifth question for audience. You have to vote. So I'll go slowly over this. This is a I will need to see this. Yeah, this is a 6 months old boy with cough, fever, and rhinorrhea. It's a very short history, just 3 days. So cough, fever, and rhinorrhea. And oops, I have given the answer. Chest X-ray is done. What would you do next? So, as you can see, there is significant mediastinal widening. So do you want to ask for a CBC or a CT chest or an MRI chest? So you have to answer this. I'm not sure if I can see this. So it's a URI child with mediastinal widening, but by the time he comes to you, he's asymptomatic and he's already had a chest X-ray done. So I'm actually not able to see the voting for some reason. I think, yeah, I've got it. So actually, I would say that majority have got it wrong. They're asking for a CBC. So what I would say is that the CBC is not really required here. Why? Because the child, what will a CBC tell us? Leukemia and lymphoma are not really seen in this age group. And this is a classical thymic hyperplasia, the so-called Sale sign. This is a typical thymic hyperplasia, which is normal for this age group. The X-ray should not have been done here. It's a simple URI, so the X-ray should not have been done here. So by asking for a wrong investigation, one ends up in a trap and one ends up getting more investigations. So just the child is well, he's only had a URI, so just leave him alone and it will just disappear with time. So I will, so just last few slides. So the thing which I just really wanted to communicate was that the common errors that we see in children with thalassemia major on regular transfusions. One is that we often see that they are not getting enough blood. One often tends to give them blood only when the hemoglobin is less than 8, 9. or even 7, 8. So one should try, suppose we look at the TIFF guidelines, the Thalassemia International Federation guidelines, one has to transfuse blood as soon as it drops to 9.5 to 10. So when a child comes of thalassemia with hemoglobin of 10, one must transfuse. One should not send him away telling that drop your hemoglobin and only then we will transfuse you blood. So they must be given adequate blood transfusion. Second, we are all used to warming blood before transfusion. So that was an old story. Now we have learned that unless it's a neonate or a massive transfusion, one need not warm blood before giving transfusion. As soon as it is released from the blood bank, one can start the blood. Third thing, which is again a difficult decision at times, is giving only one blood to children with thalassemia. So we are so used to giving 1 unit. So the dose is 20 ml per kg. So any child who's above 30 kilos should be actually be getting 2 units. So, and in a child, in an older thal who is not maintaining adequate hemoglobin, and the adequate hemoglobin means 9 to 10, one should quickly shift to 2 units of transfusion being given every 3 weekly. And each unit can go over 2 hours and the 2 units can go over 4 hours so that the child can return home the same day. So there is really no point in transfusing bloods too slowly, and one can give 2 transfusions simultaneously. So Dr. Revati, would you like to comment anything on these points? Have you had such similar experience as well in children with thalassemia?
Yeah, I think you have pointed out really good points here for guidelines for transfusing children with thalassemia major. And another common error we see is to give pre-medication with strong steroids like dexamethasone and things like that. So they don't need, because what is recommended, what is ideal is if we use a filter to transfuse them, because the use of filters, it reduces the chances of allergic reactions and febrile transfusion reactions, and that would be superior to giving them high doses of steroids before transfusion. And even saline washing is increasing the risk of bacterial infection, and to use recently collected blood, not something that is more than 3 weeks old. So less than 7, keeping their hemoglobin above 9. And if your thal child is requiring a splenectomy, or you have exam cases of thalassemia with frontal parietal bossing, that means the transfusion standards are not adequate. So we should aim to have a perfectly looking child.
Right. Thank you. Thank you. And Manas, I think we are already short of time. Do you want me to end here?
I think, sir, maybe the last slide that you have projected, we can take that question, because I think that is the most important message which all pediatricians should be getting. And also there are some questions in the Q&A section. So maybe we'll take this last question and then we'll go to the Q&A.
Sure. So this is, at what age should iron supplements be started in full term? So it's full term, not a preterm, normal birth weight, exclusively breastfed well baby. So absolutely well child. Absolutely well child, you know. So when should you start iron supplements? He's breastfed, he's well, he's full term. So what is the answer? This is not a quiz. So Dr. Shirisha, would you want to give it a try here?
Yes, yeah. So if you are looking at a baby whose mother has normal iron stores and passed on regular iron stores to baby, then
so we are talking of a community child. We have not done the mother's iron stores. It's a well child coming to you for, you know, just vaccinations.
Okay, then as per the recommendation, then iron supplements has to be started at 4 months of age. However, in Indian setup, like we all end up starting at least a month before because of low iron stores being like expected in all Indian mothers.
Right. Okay. I was actually thinking that you might say 6 because that is what the Indian guidelines say, but you've actually said 4, which is great. The American Academy of Pediatrics does say 4 months of age. For some reason, we have the the National Iron Plus Initiative program says 6 months, but many studies have shown that even at 4 months of age, the iron levels are low. So one has to give a start at 4 months of age at 1 mg per kg per day until appropriate iron-containing complementary foods are introduced in diet. And again, weaning in India tends to be really poor with a lot of milk-based diets. So giving starting iron at 4 months of age is useful. So thank you, Manas. So I'm done, and we can take up the questions.
So we have some questions in the Q&A section and also one question in the chat section. So in the chat section, Dr. Anuj Goyal has asked this question. This is about job syndrome. So Dr. Revati, if you would like to answer, what is the treatment of an asymptomatic patient of job syndrome? Age is 10 years and his IgE level is around 1800 to 1900.
Okay, so if although it's called hyper IgE syndrome, the main defect in these children is a neutrophil dysfunction, and they are prone to staphylococcal infection. So it's a misnomer, this hyper IgE syndrome. So a lot of these hyper IgE syndrome children, we can treat them just like the CGD treats with Septran and itraconazole to prevent staphylococcal and aspergillus infection and follow them up. And it's not like we jump up and offer transplant to everyone. Those who have significant symptomatic infections are the ones that we recommend transplant.
Okay,
There is also an interesting question on leukemoid reaction. I don't know if Deepak Bansal wants to answer that. How to differentiate between leukemoid reaction and PID have a high total leukocyte count.
I'll let it pass.
To add
Yeah.
one more point, ma'am, for hyper IgE management, while waiting for transplant in a significantly in a child who is getting significantly infected, we can
Because there's one question.
IVIG. Yeah.
So the question on leukemoid reaction and differentiating it from the PID, I like to take that question. So basically, when you have too many white cells and you have very mature cells present, and you have a scenario, so usually LAD presents in very young children. And what is the problem is that the neutrophils are not able to migrate because there is a migratory defect. So even when the patient does not have infection, your white cells are still very, very high in LAD. With the infection also they are high, and without infection also the white cell count remains high. Whereas leukemoid reaction comes in a setting where there is an infection going on and you have a very inappropriate response with very, very high white cell count. Then you can do a flow cytometry for LAD, which can tell you whether there is LAD or not. And to differentiate between leukemoid reaction and CML, you can do a lab scoring, and that can help you to differentiate between the two entities. So, leukemoid reaction can be a little confusing, and often we get referrals whether is it a leukemia, is it CML, is it ALL, can it be a LAD? So, these are 3-4 tests and the clinical setting where we are in, and that will help us to differentiate. So the next question in the Q&A section is about mother has a, I think we have done this, mother has a family history. We have talked, there is a question about acute generalized exanthematous pustulosis. So this is, I'm not aware of this condition. If any panelist would like to answer, anybody like to take it? No, so we'll probably give it a pass. We'll have to read this. So this is a homework for us as well. They want to ask about acute eosinophilic pneumonia, when to suspect that.
I'm assuming that if you have pneumonia with a lot of eosinophils at the same time, then one would suspect eosinophilic pneumonia and the kind of a Loeffler syndrome.
I think the picture is an interstitial pneumonitis. So you have a high eosinophil count with an interstitial pneumonitis. So it won't be like a dense consolidation. So that's when you suspect that this could be an acute eosinophilic pneumonia. So if it is an interstitial picture, but here also I would still think of infections like pneumocystis and things like that first with a high eosinophil count rather than an eosinophilic pneumonia.
Deepak sir, would you like to take this? Is Lasix pre and post transfusion required? I think it's important for the transfusion, people should know this.
Right. So answer is invariably never. So Lasix is recommended only when there is chronic anemia, really long standing anemia. And I think it is a highly abused drug before transfusion. It has kind of become like, just give it before every transfusion. Otherwise, the child will go into cardiac failure. We hardly ever see it. Only when the hemoglobin is, 2, 3, 4, and it has been a long-standing anemia that one needs to give Lasix. Otherwise, in regular cases, I think any hemoglobin above 5, 6, 7 should be all right to give without Lasix. Unfortunately, the child will go home and he will keep on peeing the whole evening. So unfortunately, just by giving Lasix, you're making his life also very inconvenient.
So you can take the next question as well, sir. Do well-fed older children need iron?
Do well-fed older children need iron? So I can give two answers for this. One is a community-based answer, and one has to follow the National Iron Plus Initiative National Iron Plus Control Guidelines, wherein all females from the age of 6 months till menopause, from the age of 6 months till menopause, which means all females should be on iron initially twice a week till 5 years of age, and then once per week till they are they attain menopause. And for all males from 6 months of age till 18 years of age, they should be getting iron. If you ask me as an individual, this thing you can do a CBC, look at the MCV, and if you really want to know, you can do an iron study. So you can have a community-based answer, and you can have a one-to-one answer as well for that. But the obesity has got nothing to do with iron profile. One could be eating junk food and not getting iron.
Yeah. Dr. Hema has asked this question. Dr. Shirisha, if you could answer this. Hypereosinophilic syndrome presents with very high counts, and we cannot wait sometimes for 1 month for definition. So, the textbook definition is 1 month. Nobody waits for that. If you have tissue involvement and lung also shows and bone marrow also shows, what would be your recommendation on methylprednisolone usage in such a child?
So it depends on whether you are giving what steroid choice you are choosing, like whether it is prednisolone, methylpred, or Dexide, depends on how the child is, whether it is parenteral or oral. So though the child is having fevers and organ involvement, if there is a lung involvement, definitely you want faster response and maybe parenteral will be better. But if the child has fever and then no significant respiratory symptoms, I will go ahead even with the oral medications like prednisolone, so that it will be easier to continue at later point also when the child gets discharged. So as already Manas mentioned, if though by recommendation you wait for a month, but with high eosinophil count, if the child is getting symptomatic, definitely you go ahead and if you have already tried other simple medications, definitely you go ahead and start steroids and continue that for 2 weeks. Usually in our experience, we have seen like good number of hypereosinophilias. In few days time, we got a response, like 2 to 3 days, you get good response, and then we were able to discharge them also.
Yeah. And I think the doses recommended are low doses. We don't have very high doses. Usually 1
mg per kg prednisolone.
Yeah, low doses of methylpred is okay. I think the next question is a kind of a repetition iron supplement to be given in a 4-month-old child with a hemoglobin of 11. So when everyone should get, I think probably, even this child should get, and we don't really need G6PD before giving iron. Dr. Revati, would you like to take the next question? We had a child with febrile neutropenia with a low WBC and responding to filgrastim, but again falls in about 2 weeks. Flow cytometry and bone marrow was normal. What should be done?
Okay. So these are probably children who have cyclical neutropenia. So whenever their neutrophils dip, they are prone to infection, and when their neutrophils are better, they look okay. So we just have to follow up these children for 6 weeks. If we have weekly blood counts, we'll know a pattern over 6 to 8 weeks when their counts dip. And these are children that may benefit from GCSF. They may only need a very small dose, maybe even just once a week or once in 2 weeks or twice a week, but we have to titrate. And if the marrow was normal and it didn't show myeloid maturation arrest, then this is not congenital neutropenia. So we can safely tide over the crisis with the use of GCSF if they come with severe infections. If they don't have infections, we can just follow up and with the dip of neutrophils, cover them with antibiotics if they are symptomatic. What is a good clue for neutropenia is to look at the gums. Any child with significant neutropenia will have gingivitis or they'll develop mouth ulcers. So if the mouth is clean and the mucous membrane is clean, then it's unlikely to be symptomatic neutropenia. If it's a girl child less than 2 years, sometimes it's autoimmune neutropenia and they easily grow out of it and they're rarely symptomatic. So just with one value, we don't need to treat. We can follow them up and make a decision based on what type of infections they're getting, especially if the marrow has been documented to be normal.
Yeah, actually, we showed one case of severe congenital neutropenia yesterday in the pancytopenia discussion, but we had to skip through the cyclic neutropenia case because of the lack of time. The next question is, when should G6PD be done if somebody has missed it at birth? I think the answer is anytime. Whenever the parents want to get the child prick, that can be done. Please give some comments on hematidrosis. So this is something, we have all seen those scary YouTube videos of hematidrosis. Would anybody like to take that? I am not an expert on this, so I would really like to
We
pass.
have seen around so we have seen around 7 to 8 cases of hematidrosis, I should say.
Yeah.
Out of them, 2 were quite tough to manage because they were very young. One was like 11, 12 months baby, and the other one was 1.5, 2 years old girl. And remaining were like adolescent or around 10 to 11 years or adolescent age group kids. So in the bigger age group kids, what we have noticed is whenever there is a stress factor, like a child has been shifted from regular school to fast track batch. There is a batch called as fast track batch in some of the schools where they put them on intensive schedule for academics. If they go into fast track batch or if they get separated from parents into hostel. So these kind of precipitating or exams and all these kind of precipitating factors will result in hematidrosis. This is secondary to stress, where you see rupture of the capillaries in the sweat gland, and the sweat mixed blood sweat, it mixes with blood and then comes out as a bleeding. It's not actually blood, but it's a fluid mixed blood. You can make out that it is not actual blood, and then you can confirm with the blood group of the same child. Like sometimes you want
Is
to
it, Shirisha, is
differentiate
it
from
sweat or is it tears? Is it sweat
yeah.
or is it tears?
It can come from, we have seen from forehead, nail bed, umbilicus, ears, nose,
Scary.
or perineum. So from different sites it has come. So
Yeah.
and main diagnosis is like you have to biopsy the lesion when they are actually bleeding, biopsy the site when they are actually bleeding to demonstrate the rupture of the capillary within the sweat gland. However, majority of them, they come, by the time they come to hospital, they stop bleeding, and then you end up like, we biopsied only few children, and then we were not able to demonstrate because they were not bleeding at that time. And it is also recommended to do ANA for these children. And mainstay of treatment is like control the precipitating factor, control their stress, and then they stop bleeding. And the other 2 kids I have mentioned who are tough to handle, they had hematidrosis secondary to autonomic nervous system dysfunction, because they were very young and we were wondering like why these kids had significant bleeding manifestations secondary to hematidrosis, and the episodes were almost like 2 to 3 per week. So significant number of episodes, and then for ANS
Are
dysfunction,
definitely very
we have,
challenging cases and
yeah,
very, I think,
so
very difficult to manage. The
yeah,
next question
but
is the
you
next
start
question.
sorry.
I said we'll move on to the next question.
Yeah.
These are very difficult
So
cases to
just
manage,
to wind up, like, even ANS dysfunction you control and they stop bleeding.
Shirisha, you should definitely write this up because you have the maximum experience and a big series of cases with you. The next is a question on about balancing the prescription for iron. So, the Dr. Prem Singla has asked this. He's asked about giving iron to thalassemia minor oblique intermedia. So, sir, we should never give iron to thalassemia intermedia. It is an iron overload state. They are absorbing too much iron from their gut. We should not give iron to thalassemia intermedia. Let's take the question for thalassemia minor. So, Dr. Deepak, you can answer this. If there is a child with thalassemia minor who has concomitant iron deficiency, would you like to do serum iron level because because of the cost, the doctor doesn't want to check serum iron level? Would you do all these tests or would you just give iron?
There are 2 situations. One is that you know that it's a thal minor. Another situation, you don't know that it's a thal minor. In the community, the prevalence of thal minor is about 3 to 4%. So many times you'll be giving iron and the child may have thal minor. So it's not a contraindication at all. Thal minor, you can give iron safely. If you know that the patient has thal minor, often we still give them iron for 3 months to see whether the profile, whether the hemoglobin rises up or not, because iron deficiency is fairly common in community. So a thiol minor could also have concomitant iron deficiency anemia. And I think it's a good practice to just give them iron for 2-3 months to see whether the hemoglobin really rises or not. If one really wants to be scientific, one can ask for serum ferritin value, but then it's really sort of then pulling things up then.
Somebody's asking about withholding feeds while giving blood transfusion in newborns. Would you do that?
Just feed as per the normal indication. Blood transfusion has got nothing to do with eating, drinking, anything. Yeah.
Somebody's asked about salt intake for children. I think I'll just give that a pass. We are not really good with the salt part. Probably yes, iron, maybe we can tell. What drugs do you give to Job syndrome patient before referring? I think Septran, itraconazole, madam has answered this question. So these are the drugs that are used for Job syndrome. A 1-month-old baby with hemoglobin of 7.5, active, playful, no evidence of hemolysis, no other finding, mother healthy, hemoglobin 12 without any symptoms. How do you proceed and management? I think it is just management of anemia, approach to anemia. What we read, we need to look at MCV, we need to look at RDW, we need to look at peripheral blood, we need to look at RBC count. So this is a full chapter on its own. Maybe, we need to really evaluate this child as per how we evaluate any child with anemia. Role of IVIG in febrile neutropenia, no, unless you have very severe immunoglobulins, we don't need that. I think we'll just skip that. Dr. Revati, can you answer the next question? 8-year-old boy, chronic ITP, secondary causes ruled out, on dapsone and steroids intermittently for 2 to 3 years. Still platelet is 10,000 and child has some mucosal bleed. What are the options?
Okay. So here, if he's been on dapsone for 2 years and his platelets are still less than 10,000, I'd certainly recommend not continuing dapsone, because clearly it's not made any difference. And if the child has only intermittent skin bleeds, not much mucosal bleeds, there is a case to just wait and watch and use steroids when there is an exacerbation of bleeds, maybe just for a 5 to 7 day course. There are good drugs available recently, so we can use if there are frequent bleeds, then there is a case towards using because with ITP, chronic ITP, definitely I would like to rule out an underlying autoimmune disorder, a primary immune deficiency. You've said you've ruled out secondary causes and viruses. Once these are ruled out and it's an immune thrombocytopenia, we have to cover both causes of etiology, reduced production, elimination of pulse dexamethasone and L-thrombopag is something that we could try in this child. 6-month course to see if they would get into remission. But there are other options like rituximab 4 doses. But the thing is, it's all has to be tailored to that particular child. In majority of the children, if they are asymptomatic, we can just follow them, and with time, they are going to improve.
So I think wait and watch is one option. The other options are romiplostim, Revolade, which is L-thrombopag, rituximab, and very rarely splenectomy. And the next question is, a child is G6PD deficient at birth and repeat test at 1 month shows normal value. What is the explanation for this? Would anybody like to say?
So we know that when there is hemolysis, the young red cells come up and the test can be normal. But I understand from where this question is coming. This is a common situation wherein at the neonatal time, because of neonatal jaundice, G6PD is done, which is low, but later on it is normal. I think this is a very common clinical situation, and I think one can just ignore it, because I think we often see that in clinical practice, G6PD deficiency is not a very significant concern. We hardly ever see drug-induced hemolysis. The typically time that we actually see hemolysis is when they get viral hepatitis and then they have acute anemia. So I think, I don't know whether other panelists will agree with me. I think G6PD deficiency is not such a big deal as it is made out to be. And I think if it was low in the neonatal period and is normal after 1 month, I think we can just ignore it.
Yeah. So mechanism of iron overload in NTDT, as we are not transfusing, as I previously said, it is the GI absorption that is going on in these patients. So they absorb too much of iron. What iron preparations do you commonly use? Dr. Deepak, would you like to say?
So Government of India says ferrous sulfate, and it works really well. The adverse effects are made out by adult physicians. I think as pediatricians, we hardly ever see any adverse effects of oral iron. The GI side effects should not be highlighted because I don't believe that we have much GI side effects in children. If you tell them, then the mother will think that they have them. But a problem with ferrous sulfate is that the shelf life is low. So often we use ferrous carbonate and ferrous ascorbate. Any simple preparation of iron, what is more important is compliance and telling the parents that whenever there is URI, not to stop iron, and whenever there is diarrhea, not to stop iron, and whenever there is fever, not to stop iron. So what is more important is compliance and not the preparation which you're using, the dose and the compliance.
I think the questions are just pouring in and pouring in. Maybe I'll ask Dinesh or Shalini to tell me what to do. I think maybe we can wind up and then try to answer the questions later because we have already touched 4:30. Dinesh, would you like to say something?
I think more questions will be answered in WhatsApp group. Can be answered there.
I think we can take the other questions in the WhatsApp group. It's already almost 2.5 hours.
Yeah.
So I think people are in hurry also. It's the last day to wind it up. So I thank you, Dr. Manas. And with this, we are coming to the end of this 4-day mega academic event on the pediatric hematology. It is an emotional moment for me and our whole team to depart from such a latent audience, but we'll surely be connected through WhatsApp group. I request Dr. Manas not to dissolve that group. And Facebook, we have Twitter account and also the YouTube too. I hope that you enjoyed the session and learned from our reputed speaker and panelists. If still any doubt, Dr. Manas and our whole faculty will be there to solve your doubts through WhatsApp and the other medias. I sincerely apologize for any shortcomings from our side. We tried our best to give the best to you. Still, in case of any technical problem, content problem, or any other problem, please forgive us. We'll shortly be posting a feedback form in the WhatsApp group. And I request you all to kindly fill this form and help us to improve ourselves in future. IAP North Delhi keeps on doing many academic activities, and I request you all to join us in future also. To keep yourself informed, and I request you to kindly join us through our Twitter and the Facebook. Coming Wednesday also, we have planned a very good workshop on the parenting, especially for the pediatrician, and we'll be posting that link in our WhatsApp group. I request you to kindly join that unique and very useful workshop. There are no registration charge for that workshop. Now, not taking much of time, I want to thank my whole team from IAP North Delhi for working tirelessly. Our technical support, Mr. Amit Harish and Mr. Harsh Gupta, our speaker and panelist, Dr. Bharti, who also answered most of your queries on the Zoom, and special thanks to our hero, Dr. Manas, who is the main brain and hard work behind this conference, and it's a successful event. And the last but not the least, I really thankful to the all delegates who listened to us patiently and spared their precious time for 4 days despite so much busy schedule, and many of you being doing great work in saving life in the pandemic, Corona pandemic, and you are really a Corona warriors. Thank you very much.
Thank you,
Thank
Dinesh.
you.
Thank you, Shalini. Thank you,
Anything,
Manas.
Dr. Manas, you want to say?
I just want to thank Dinesh and Shalini because they have done the real work. I've just, asked everyone to come and join and, present whatever they thought was, relevant for our pediatricians. Nothing can be perfect. We have made our mistakes, but I think we had 500 people, and on average every day there were at least 200 to 300 people joining in and attending the sessions, and equal number on the YouTube live. They were watching you about these pediatric hematology discussions. So thank you, everyone. Thank you, Anuj. Thank you, everybody who's here. Shalini, Dinesh, Shiri,
Thank you so much.
Shobna. Thank you, everyone.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.
Bye bye.